No, this is good. This is good. Oh my God. That's much easier. I can't believe I was just going to talk without a microphone. Okay. Okay, great, great. All right. All right. Thank you. Okay, so I like that this is kind of a nice comfy crowd here. I'm thinking that this year I'm going to start off with something a little bit different. I'm thinking that I want to kind of get to know you guys and kind of learn a little bit more about what you're hoping to learn from today. I have some things prepared, but then I want to open it up when I'm done with my slides that I've prepared and really make this a discussion because of course there's going to be things that I don't cover. So I'm thinking if we can go around and just say maybe you don't have to say your name if you don't want, but you can say your name, where you're from, and like what brought you to come watch this talk today. So are we okay with that? You want to start? Yeah, thank you.
Sorry.
Perfect.
Hi, everyone. My name is Amber Ferguson. I'm actually a journalist at the Washington Post, so I'm covering Camp Breastie, and I've done a lot of stories about breast cancer. But why I'm here is because male breast cancer runs in my family. My mom has two brothers who've had it, and her grandfather died from it. So I'm curious if I should get tested.
Okay.
So that's why I'm here.
Perfect. Perfect.
Hello again. I'm
Hi.
Maria Montoya. I have a rare cancer syndrome called Lee-Fraumeni syndrome. I'm hoping to just learn something new, different, more. I love learning and knowledge, so I'm pretty much open to just hearing and seeing what I find.
I love that.
I am Colleen. I have Lynch syndrome, and I am always curious to see if there's new links between breast cancer and Lynch syndrome because I really don't. I feel like there is a connection, even if it's not proven yet.
I'm Megan. I'm BRCA1 positive. I had my mastectomy done last year, but family history has ovarian cancer in early 30s, so I'm just kind of wondering when I need to act on that.
Hi, I'm Paola, and basically, I'm just here to learn as much as I can.
Amazing. I'm here to teach you. So I'm happy about that.
I'm Ricky Lieberman. I'm from Chicago.
Woo!
Are you from Chicago?
I am actually originally, yeah.
Live in Evanston. And as of June 28th, it's been 25 years that I had breast cancer. But I do have the gene, the BRCA gene, and this is who I gave it.
My name is Randy. I'm from Chicago too, and I have the BRCA1 gene mutation, and I'm here to learn more about it.
Oh, I'm really glad I did this. I love learning about all of you too.
Hi, I'm Emily. I'm from Connecticut. I have the BRCA1 gene, and my bestie is a licensed genetic counselor who also helped me through my cancer treatment.
Hi, I'm Bestie. Also, you can call me Sarah. I'm from Florida. I have a rare genetic syndrome as well with familial polyposis due to an APC gene mutation. Causes a high risk for colorectal polyps and colon cancer. And I'm here as your camp genetic counselor to help Dena out as I've been in the clinical practice for 15 years.
Hi, I'm Sam. I'm from Boston. I have the BRCA1 gene. My mom had breast cancer and ovarian cancer, so just here to learn more.
Hi, I'm Katie. I'm from Rochester, New York. I have the BRCA1 gene. I'm here because I really like the content that you post online.
Thank you.
And I volunteer with Force, and I really like how you really break things down and it's like so digestible, so it helps me be a better peer navigator when you teach me stuff.
Oh, I love that. Thank you for sharing that. That's awesome.
Hi, I'm Aaliyah. I'm also BRCA1 and a triple negative survivor and from California. And I also love all of your Instagram content.
Thank you.
I'm Kim. I'm a triple negative breast cancer survivor with a strong family history, but no
known genetic mutation, so they're suspicious. So I always like to just come and see the most up-to-date stuff you have. And I have sent your content to so many people within my family that ask about different genetic testing and what it means. So,
thank you.
Hi, I'm Jen. I also live in Boston. I heard someone else was from Boston down there. Hey. I have the BRCA1 gene mutation, and I recently kind of posted my journey on my social media, and I had so many friends come out of the woodwork, kind of like asking me questions, and I answered them the best of my ability, but mostly I send them to your Instagram. So kind of just here to see if I can learn a little bit more that I can help some of them.
Oh, I'm loving that that my Instagram is helping you. That really means a lot to hear. Thank you.
Hi, I'm Elise. I'm from New York, and I haven't seen your Instagram page, but now I will. I have uterine cancer, and I asked my aunt about genetic testing, and she said breast cancer usually doesn't come from like your kind of cancer, but I really don't know why. And I have dense tissue. I have had biopsies, so I just wanted to see what's it all about.
Hi, I'm Nicole from Connecticut. I don't have a genetic mutation, but I work in healthcare, so I'm kind of a nerd and I want to learn more about genetics because I really don't know much about it.
What do you do in healthcare?
I'm a pharmacist.
Okay.
hi, I'm Anna. I'm from Seattle. I have the BRCA2 mutation. Breast cancer runs in my family, but I'm curious to know more about like the other cancer risks, since I know that they talk about breast and ovarian a lot with BRCA genes, but there are other cancers too. So, yep.
Hi, my name is Katie. I'm coming from New Jersey. And I'm an oncology nurse practitioner, here to learn more. Came to support the panelist or the moderator who did the after presentation. And again, I'm just here to learn more from you. And I just followed you on Instagram.
Yay. I'll have my Instagram up for anyone who's not following, if you have service.
Hi, I'm Cassie. This is my first time speaking to this mic. I'm from Chicago. I'm a BRCA2 previvor. And I guess we're saying what we're interested to learn here is that I had my testing 9 years ago, so I really haven't been up to date with everything. So yeah, I'm sure a lot has changed in 9 or 10 years, so that's what I want to know.
Hi, my name is Olga. I'm a BRCA1 previvor with a strong family history. So my BRCA1 mutation is a founder mutation from West Africa, and the expression can be correlated with the transatlantic slave trade. And so for me, I'm just really interested in learning more about hereditary cancer and other, what the literature says about other founder mutations.
Hi, I'm Mary Lou. I have 2 mutations, PALB2 and RAD51D. I'm a survivor of breast and ovarian cancer from 25 years ago and just recently was diagnosed with breast cancer again. I have 3 daughters. My oldest has the RAD51D. My middle has the PALB2. My youngest has both like me, and she is metastatic stage 4 breast cancer, and just want to know what information I can give them to make it better.
Yeah.
Hello, my name is Nicole. I'm also from Connecticut, and I also work in healthcare.
What do you do in healthcare?
I'm a nurse, and I was attracted to this panel because I have a CHEK2 mutation, and I haven't heard anything about it since I've been here. And I was tested last year when I was diagnosed with stage 2 breast cancer. And I also was curious, my mom had genetic testing done because we were trying to figure out where the mutation came from, but she's in treatment for multiple myeloma, and she was told that the testing might not be accurate. So I'm curious if we should do anything else about that.
Hi, I'm Kate. I'm from Vermont. I'm now an 8-year breast cancer survivor and ovarian previvor. I had my ovaries out at the same time. I do have 2 kids, and I do have a BRCA2 mutation, and my sister has it as well. And I have 2 friends who recently found out they also have BRCA2 mutations. And especially with my kids, it's always on my mind. Just to keep up to date with everything as they grow up.
Hello, my name is Laura. I'm also from Connecticut. I am a MBC thriver, and I have 2 daughters, and I'm really trying to get as much information as I can for their future health care.
Great.
Hello, my name is Taryn, and I am from Colorado. My mother died of breast cancer in 2008. My grandmother died of breast cancer on my paternal side in 1999. And my auntie on my paternal side also has breast cancer. And they keep telling me there's no reason to test me. So I don't know what to do. And that's why I talked to you this morning, and I'm hoping we can get some information so that we can move on with that. So thank you for being here.
Thank you. Did we get everybody?
Is that everyone?
Okay, thank you so much. That helps me a lot to just understand how I'm going to tailor kind of some of the things I'm saying. So I'm going to stand up because in a skirt like this short, it's not so fun to sit down. So I am a big believer in foundational knowledge. So I know some of you may know some of the things that I'm saying, but what I find when I talk to patients one-on-one is that sometimes I'll say something or I'll explain something and they'll say, oh, I didn't realize that's what that meant, right? And so I think it's really important to kind of start from the very beginning when we talk about cancer genetics to really understand a very simple way to grasp these concepts, but also to explain to your family members and to understand how these things get passed down. And to then, once you know the basics, you can then understand the treatments and the other prevention strategies and why they work, right? And why it's important that people get genetic testing. So we are going to start all the way from the top. And before I do that, I just want to explain what a genetic counselor is. So how many of you have worked with a genetic counselor? Raise your hand. Oh, amazing. I'm so happy. How many of them were in person? Raise your hand. Okay, great. Was anyone on the phone? And was any of them under 30 minutes? Okay, a few of them. Okay. Yeah. So there's a lot of different models of genetic counseling. And the model that I love is the one where we can really spend a lot of time talking to our patients and answering your questions and really taking that family history, that personal history. And that's what most of us do. Because of the way that our healthcare system works, it doesn't always work that way. So I just want to preface all of this with genetic counseling experiences may differ from person to person because of the limitations put on us by our healthcare system. But typically a genetic counselor, so in order to kind of set the stage for this, most physicians and other healthcare providers only have a very basic genetics training in medical school, if any at all. Usually it's only a few weeks or a few days, and it's usually not taught by people who are practicing in the clinic. And genetics is always changing. It's one of these areas of science that's literally like every week there's new things coming out and new discoveries being made. And so genetics is also the future of personalized medicine, and any healthcare team working with genetics needs someone who understands the ever-changing field and understands how to navigate this care, how to use insurance to get things covered, and all the kind of hacks to do that. And so that's a lot to ask of somebody. That's a full-time job, right? And so to expect that a physician who has so much on their plate, or any other type of healthcare provider who already has so many other roles, to be able to stay on top of all these genetics changes and findings and recommendations is really asking too much, to be honest. So that is why the field of genetic counseling, especially in the cancer space, was born, was to be able to have somebody that filled that role, to be able to help patients navigate these things. And so genetic counselors, we stay up to date on the latest research and recommendations in genetics and genetic testing. We translate complex information to our patients, communicate with healthcare teams, and we are trained to deliver this information in a way that is ethical for you and for your families. So, I'm Dena. I go by Dena DNA online, and I am a genetic counselor and a content creator. I create content for Instagram because I realized when I was in graduate school that no one knew what a genetic counselor was or knew if that they would benefit from it. And if you have a service that's really great and will help a lot of people, but then nobody knows about it, then what's the point, right? Because then people aren't making it there. And so I set out to make it my mission to do whatever I could to really increase awareness of genetics, genetic testing, genetic services. And so I started my career as a genetic counselor in the UCSF Cancer Genetics and Prevention Program, and later became an endowed genetic counselor of hereditary GI cancer prevention, and then ended up leaving academics after a few years to move because of my husband's job, and then I started my brand, Dena DNA, full-time, where I educate about this stuff. And then I decided that I actually really missed seeing patients and being able to help people, so I founded my own private practice, Malibu Genetics, which I can talk about later. So that's a little bit about me. So now I want to explain to you in the simplest terms that I can what actually causes cancer from a genetics point of view. And cancer really, we think of it as a disease of aging cells. So any organism that has cells that grow can actually develop a cancer. So that's animals, that's plants, and it is literally at the cellular level, this uncontrolled cell growth. And there's a lot of reasons that that may happen. So when we look at all the cancers in the general population, most of them actually fall into this category that we call sporadic. And I'm going to explain in a second what that means, but just kind of take this in. So most are sporadic, and then we have some that are familial. And we find that about 10 to 15% are in this category we call hereditary or inherited. And that's what we're really focusing on today. So in a sporadic history, we'll usually see one person affected with probably a more common type of cancer at an average or older than average age for that type of cancer. And usually they don't have a family history. And these are usually due to things like environmental exposures or lifestyle or some of these cancer risks like smoking, tobacco, radiation exposure. It's usually a lot of different things that add up to then cause a cell to become cancer. So it's not typically genetic. So most cancers, it's not typically inherited, but all cancer is caused by these genetic changes. Then we have familial. So in familial cancer histories, we have multiple people in a family that are affected, usually at an average or older than average age. And we see this clustering, but this is kind of the in-between category. So this is when there is a family history. We know that there's probably some interaction between genes and environment together, but it's not necessarily a single gene change that we can test for on a genetic test. So I'm going to talk about risk models in a little bit, but this is going to be that middle category where we kind of think of like somebody having a moderately increased risk. And so they still may qualify for testing, but we can't actually find it on a genetic test. There's no one factor that's greatly contributing. And then we have this hereditary cancer. So what a lot of you, shared that you carried one of these gene variants, and that's going to be this category. And in these families, we typically see multiple generations of cancer at younger ages than average for that type of cancer. And this is caused by a single genetic change that gets passed from parent to child. However, not everybody with a genetic variant that causes disease or disease-causing variant, mutation, whatever word you want to use, not everyone with one of those will actually have a family history. And there's a lot of reasons for that that I can get into later. But because of that, the guidelines for getting genetic testing are typically based off families that look like this one, the hereditary. But what we're finding as more people are tested is that a lot of people with these mutations don't actually fit guidelines. As I was saying earlier, that I felt that guidelines are not always fair in who can get genetic testing. So these are the different categories. And so just to give you kind of a little peep inside my head, when I look at someone's family history, we take this is called a pedigree. We take a pedigree when we're looking at someone's family, and we know that things like a lung cancer or a cervical cancer are usually not associated with an inherited syndrome. They're usually not something we see running in families because lung is mostly caused by smoking or some sort of environmental pollutant. And cervical cancer is caused typically by viral infection like HPV. But there are some rare exceptions to that, but that's a general rule. When we think about breast cancer, we know that 1 in 8 women will develop it, and still most of those are going to be in the sporadic category. And we don't always know who those 1 in 8 will be. And that's kind of what we're going to be talking about in a little bit is being able to figure out if someone has a breast cancer, which of these categories are they in? And the average age, I should mention, of breast cancer is about 62 in the general population. So when someone has it younger than that, that's when we're starting to think, okay, maybe they're coming, more towards this side when we're thinking about these categories. Then when we think of things like ovarian cancer, I realize I'm getting ahead of myself because I have a great slide on this, but some of the different gynecological cancers will have much higher chances that there is something, that there's an inherited mutation associated when we're looking at someone's family history. Okay, so what are cancer genes? So I heard some of you say I have the BRCA gene, right? We actually all have BRCA1 and BRCA2 genes. So that's the name of the gene, but what you actually have is a gene variant or a genetic mutation, right? So I never, it's so much easier to say I have the BRCA gene anyway, so, but the technical actual way that's correct to say it is that you have a genetic variant or a genetic mutation. So what are cancer genes? So in every cell, we have about 20,000 genes, and they all have different jobs. And generally, and of course this is definitely oversimplifying it, but I like to just think of it like this. A gene, the gene's job is basically, it's a recipe that the cell reads through to create a protein product. And our body is made of lots of proteins, and that's what makes up our bodies, and it tells our bodies how to function. So when a gene is working correctly, it makes the correct protein product. But when there's a spelling change or something wrong with the gene where the cell can't read it correctly, then it may make an abnormal protein product or no protein product at all. Okay, so I'm guessing you're telling, okay. So cancer genes, like I said, I'm putting this in quotes, these genes are good genes. They actually protect our cells from becoming cancer. So BRCA, we want BRCA genes and we want them to work well. Same with all these other genes. We want them to work and to do their job of protecting our cells from becoming cancer. So it's really when we have a genetic variant that it then becomes non-functional or doesn't function in the correct way that we consider somebody to have an inherited mutation. A condition. So how is this passed down? And this is, again, a very simplified way, but everybody of all those 20,000 genes, we have 2 copies of every gene. We get 1 from our mom and 1 from our dad. And typically in a sporadic cancer, so if we were to take somebody with, let's say, I'm going to use an example of a breast cancer at age 80 and no family history, and we, let's say, know it's truly sporadic, we'd be looking at all their genes and we'd see that they were born with all these cancer genes working and functioning correctly. And let's say 30 or 40 years goes by and something randomly, a cell in their body randomly acquires a mutation for some reason, and sometimes we know why and sometimes we don't, then they still have this backup copy, right? And so the second copy can still do its job and protect the cell from becoming a cancer. But 30 or 40 more years go by and a second mutation is acquired, and now that cell no longer has that protective mechanism and will become a cancer. So in this situation, it took almost 60 to 80 years for this cell to then become a cancer. Whereas if somebody, let's say we rewind, and somebody is born with one of these genes already not functioning correctly, and then that gets passed down to a child, then that first 30 or 40 years comes by and the first mutation is acquired, and now that person may develop cancer in half the time. So that's kind of we call this the 2-hit hypothesis, or just a really simple way to understand why people who are born with something will develop cancer faster than somebody who is born with both of their copies of BRCA working. Yeah, you want to ask a question? Acquired means that a random cell randomly had a mutation when it was splitting. So it wasn't something that existed, and then during a random event when it was splitting, it acquired it. But great question. And please feel free to raise your hand. I want this to be interactive. Yeah. Oh, good question. So in this example, I'm just showing one gene. So if you have, you said you have which PALB2 and okay. Okay, so those are functioning separately. So you can imagine that one does not affect the other. So if one of them, so you would look like, okay, I'm just gonna walk over here. You would look like this, but at both of those locations, but it's not gonna look like this because you would still have a normal copy of each of those genes functioning. Right, so you have you would be born with one copy of PALB2 working and one copy working, the other copy not working. And the same thing with the RAD51. Yes, at those genes, yes. Does that make sense? Great. So those would be basically independent of each other, right? Okay. So that's just, I think it's an interesting way to conceptualize how this works. So when we think about what does this mean when somebody who carries one of these inherited cancer risks passes it down. So every time they pass it down, there's going to be a 50% chance that they pass that working copy down and a 50% chance they pass the non-working copy down. And so what that ends up being is that it's a 50% chance that a child will inherit that copy and then a normal copy from the other parent, assuming the other parent has a normal copy, and a 50% chance that they'll just inherit 2 normal copies. So anybody, I'm sure your genetic counselors have told you, you have a 50% chance of passing on something that is autosomal dominant. So the vast majority of these cancer genes are inherited in what we call a dominant method or fashion. And then the other thing is that a non-carrier cannot pass this to children. So if somebody did not inherit a mutation, then they cannot pass it down. So it ends there, which is really exciting when it comes to the innovations that will allow us to basically end this in somebody's genetic line. Okay, so now let's say that we see somebody who has a tumor. And you've probably heard, has anyone heard of somatic testing? Or tumor testing, right? So that's going to be different than the testing the germline testing, which I'm going to be talking more about. So when somebody does have a tumor, we're always going to find genetic mutations in that tumor, and most of those were acquired over time as they were aging. So they were not a change that they were born with. And so when you go into an oncologist and you test the tumor itself, they're looking at the genetic changes within the tumor for treatment decisions. So that can help them understand how to treat the tumor, but it doesn't tell them if you were born with those changes or not. And so that's why we'd want to use germline genetic testing to look at someone's blood or saliva to see what changes they were born with versus tumor testing, which is looking at the tumor for treatment decisions. So I like to just clarify those are the 2 different types of genetic tests. And actually, I really should have put a slide on cell-free DNA. Yeah. Yeah, so because germline genetic testing is looking at the genetic code you were born with, are you asking about like how early is possible or how earlier should you do it? Possible. So you could basically test an embryo for these. And then all the way up to, somebody's deathbed to when they're 101. So those genes, the germline genetic code doesn't change throughout your life. It's the same from birth to death. So technically, you can test at any point, but we're going to get into, when you should test, because that's going to be different depending on someone's family and different situations. Was there another question? Yeah. Yeah, great question. I'm going to be talking about VUSs, but VUSs are inherited in the same way. So basically a VUS is a different version of a gene, and you may or may not pass that version down. It's the same 50% chance that you pass that version versus a version that's better known. I think it'll make more sense when I talk about it, but it's going to be the same type of inheritance there. Okay, so germline genetic testing, typically we do it on blood or saliva or something called a buccal swab, which is where you get skin cells from the inside of the cheek. Okay, so we're going to talk first about breast cancer and then the gynecological cancers, but I also like to have a foundation so that you understand the anatomy if we mention a term like ductal or lobular. So the two main types of breast tumors we think of are either in the milk ducts or the lobules that produce the milk. So that's what that would look like in a female breast or a female assigned at birth. And in a male breast, it would look like this. So because males have these ducts, they can still get breast cancer because that's the type of tissue that they would develop it in. It's just the chance of a male getting breast cancer is a lot lower. However, if you have an inherited genetic syndrome, it's going to be higher. So male breast cancer is definitely something we're going to cover. Okay, so when I think about risk, because we're going to be talking a little bit about risk and how these genetic changes fit into risk. We know that there is this population risk. So there's the general risk that anyone walking around without knowing much about them, we can assume that they're in, which is that kind of low, like about 12% risk range. And then it starts to climb with different risk factors. And one of those is family history. So when someone has family history of a cancer, then their risk is going to be a little bit higher. Probably because of shared environmental exposures, but also lots of shared genes in general. But then we also have these moderate risk genes, which are going to be an increased risk, but not as high as things like BRCA or PALB2 or Liframini when it comes to breast cancer risk. And so as you can see, as the risk goes up, actually this chart doesn't show it, but as the risk goes up, it's actually more rare. So when we think about variants that are a little more moderate risk genes, those are actually more common than a high risk gene in the population. And there's going to be more people that have this increased familial risk than there will be people who have these moderate or high risk genes. So it kind of fits this curve when it comes to risk. Okay. So when we think about the breast cancer genes, this is just showing you like a great graph that charts the risk. But as you can see up here, the P10 all the way down to BRCA, TP53, which is Liframini, all the way down to this PALB2 are what we kind of are considering in that higher risk category. And then we have ATM and some of these that are lower. This isn't the perfect chart, but these are going to be they're going to be in a lower risk category. And so the reason I show you that is because what we recommend for screening purposes is going to be different whether you're in a high risk or in a more moderate risk category. So what does that actually look like? So the average risk, somebody who has an average risk who doesn't have an inherited gene mutation, it's recommended to do the annual mammogram starting at 40 and also the annual clinical breast exams. We would not recommend them surgically removing their breasts, and we would not recommend going on a medication for lowering breast cancer risk. Someone at moderate risk, their mammograms may begin younger than age 40, especially depending on family history. We would customize that to the patient. And then additional imaging like breast MRI may be recommended, or even ultrasound in some cases. It depends on the situation. And then the clinical breast exam may be every 6 to 12 months instead of annually. And a risk-reducing mastectomy in these situations are not usually recommended, as well as the tamoxifen, but it could be an option. But tamoxifen is a medication you can take that can help lower risk. It may be an option, but it's not always an option. And then the high risk, these are when you actually have the genetic change. That's where we're talking about annual MRIs and starting at 25 and adding in mammograms at 30, the clinical breast exams every 6 to 12 months. And then the risk-reducing mastectomy may be an option in these cases, and that's something that can be discussed. And then also the medication could be an option depending on how old you are and your situation and other factors. So this is typically like a very simplified way of looking at the different risk categories, but it really truly is a spectrum because we also look at other things besides just your genetic change to try and understand where you fall into that spectrum and then put you in that risk, in that screening protocol. Okay, so there's something called the National Comprehensive Cancer Network, and a lot of us in genetics and in the cancer space follow their guidelines. So their guidelines for, I'm going to start with breast and then go to the GYN cancers, but the breast cancer guidelines say that anyone with a personal history of breast cancer under age 50 or in one of these other categories is going to be, it's recommended that they're offered genetic testing and their minimum gene list is up there. Now, if you ask me, this is really small because we have the technology to order more genes to look at things that are more moderate risk. These are really the high risk genes. And if we have that technology and we can get that information, then why wouldn't we do that, right? It's the same price. It's the same test, really. We're just asking them to look at and analyze a few more genes. So there are actually around 70-something genes we know that are associated with different types of cancers, and there's also a lot of overlap. So what we once thought was just a breast cancer gene, we now know may overlap with other syndromes. Like you were mentioning, like even with Lynch syndrome, there's still some question to whether there is this increased risk of breast cancer, and if that means somebody should be screening more or not, and if we should look at other risk factors, in addition to just the Lynch gene. So we're really learning a lot about these genes, a lot more than we once thought. And so we can see that there's a difference and a shift because the American Society of Breast Surgeons actually recommends that genetic testing should be made available to all patients with a personal history of breast cancer. So all those stipulations that I showed you on the last slide, they don't exist here. They're just saying test everybody. And there's a lot of major medical centers that are going ahead and testing everybody, regardless of these guidelines. And then this also says that people who tested before 2014 or even more recently than that would benefit from update testing because they may have only had BRCA 1 and 2, and there's all these other genes, and I'm going to touch on those. But it is so important that we look at all of these at the same time because people knew so much about BRCA, a lot of times physicians or other healthcare professionals were not ordering other genes, and then we were missing people, and they were developing preventable cancers. So it's really important that if somebody had an older panel, that they have an updated panel. And here's a little bit more about these syndromes. And how many, let's see, today, we've heard you guys with 3 of these earlier. So BRCA, of course, is the most common. So the general population frequency in the population is about 1 in 400. But in Ashkenazi Jews, so people with Eastern European Jewish ancestry, it's actually 1 in 40, so it's 10 times higher. So there is, if you ever hear or you're ever asked, do you have Ashkenazi ancestry, a lot of that is because there's much higher rates of BRCA. And honestly, there's also higher rates of ATM and CHEK2 and some other founder mutations there. And then what we're finding is also in the Black population, there are higher rates of BRCA and some of these other genes as well. And in other, more minority populations that weren't as well studied, we're finding they have different frequencies. And so it's really important that people get, again, these full panels when they're doing cancer genetic testing. And so we're going to move on to gynecological. So gynecological cancer, GYN cancer, includes vaginal, cervical, ovarian, fallopian tube, and uterine. But in the genetics world, we really focus a lot on the uterine and the ovarian and fallopian tube cancers, because those are the ones that can be commonly linked to things like Lynch syndrome and BRCA and some of these other genes. So when we look about uterine or what we call endometrial cancer risk, the top one here, MSH2, is this condition called Lynch syndrome. And then there's also this gene called P10, and then some other Lynch syndrome genes. And so these are going to be the genes that should always, always, always be included on this panel. But again, it's easy to get the panel, so it's better to just do all of the cancer genes at the same time. And then there's also the ovarian cancer genes. And so the most common hereditary form of ovarian are going to be BRCA 1 and 2. And then you have your Lynch syndrome, your RAD51D and C, and then some of these other ones as well. Okay, so one of my favorite studies is this one where they actually looked at 12 different genes associated with ovarian cancer, and they were looking at a huge database of ovarian cancer patients, and they actually found that 24% of them had a pathogenic variant or a mutation. 24%. That's about 1 in 4 cases of ovarian cancer. That's one of the highest rates out of any of the cancer types. And so the recommendation is actually that every single person with ovarian cancer be offered genetic testing because of this, right? And not just for prevention, but because it can guide treatment as well. So these are the NCCN guidelines for this. So the top one is going to be talking about anybody with ovarian cancer should be offered genetic testing, but also anyone with ovarian in a first or second degree relative. So it's not even just the person, but their relative, their close relatives. And that includes fallopian tube and peritoneal cancer. And then for endometrial cancer, everybody should be offered Lynch syndrome, and then a number of other genes as well. Okay, I feel like oh yeah, and then this is the guidelines for endometrial. I'm gonna kind of skip ahead because I feel like we can kind of discuss this a little bit more. So if you do not fit criteria, so this is a big one. I know a lot of you have already had genetic testing, but is there anyone that's kind of considering getting it again or getting it for the first time? Okay, great. So one of the biggest messages that I want you to walk away with is that it usually is covered by insurance, but if it's not covered by insurance, it should never be more than $250. So you can call the lab and ask for the cash pay rate. Now, I say that now, but because of our current economy and this political environment that we're in, a lot of things are shifting. This is the price as of now. If you're watching this later, I'm not going to be able to guarantee that that's always going to be the price. But as of right now, this is the price at most of the major laboratories for a germline genetic testing panel that includes over 70 genes. So again, if your insurance doesn't cover it, cost should not be a barrier. It should never be more than $250. And if that is a lot for you, you can also ask for financial aid, which is available at most labs. So always, ask for patient pay rate or financial aid. So cost, again, should never be a barrier. Okay. Whew, I feel like I'm giving you so much information right now. So I'm going to switch to this prevention and risk reduction because I think this is really the why. I'm giving you all this science and numbers and data, but why is this relevant? And the reason it's relevant is for prevention / risk reduction, because we can not really ever truly prevent something, but we can very much lower the risk for it. And we can do that by doing things like earlier or more frequent screening tests. And this is one where it's finding something much earlier so you can treat it much earlier. So this is not necessarily prevention, but really helping us get there at an earlier stage if there is anything there. And then medications for prevention. So an example would be people with Lynch syndrome can take aspirin therapy. We found that taking high doses of aspirin, or a specific dose, can actually lower the rates of certain cancers associated with Lynch syndrome. And that's a really exciting thing because it's such an easy type of medication to be taking and to get. And then there's also lifestyle changes like exercise, diet, and other things. And then surgery in cases like a preventative mastectomy or oophorectomy. And so all of these things can be done to really significantly lower the risk for something to develop or to find it early. And this is for patients, but also for their relatives. So if you test, you're now giving your relatives the gift of this knowledge so that they can then have these interventions as well. And I always like to say it's prevention, but it's also treatment, which is really exciting. So PARP inhibitors are a specific type of treatment that are used for specifically cancer cells that have BRCA mutations and have a lot of great results. And then immunotherapies, which can be used in tumors that are what we call microsatellite unstable, or people that have tumors due to Lynch syndrome. So these are more targeted treatment plans that someone can only really know to use if they know they have one of these genetic changes or conditions. Okay, so when we talk about genetic testing, there's a lot of different types that someone can get. So there's something called single site. So actually, I want to take a little survey of you. I know you told me the genes that you have, but do you know the name of the mutations that you have, if anybody has a mutation? You know the variant. Okay, yeah, so you know the name of the variant? Oh, you have it tattooed on you? Perfect. Wow. Okay. Wow. Okay, so she knows her stuff. Wow. I mean, it's kind of, wow. Oh my God, that tattoo. Okay, we're going to have to take a picture of that later. She has a double helix tattoo. Breastie TV, we got to look at that later. Okay, but here's the thing, like, you don't actually have to memorize it or know it, but it should be accessible to you. And one of the things that I don't have it on here, but like, I'm going to use the CHEK2 as an example. So the CHEK2 gene, do you know your... Okay. It's an exon. Okay. Okay. So with CHEK2 and with some of these genes, what we're finding now, and this is kind of newer in the last few years, at least when I go to these academic meetings, they're now talking about how the risk may actually be a little bit different depending on the specific variation you have within your gene. So one person with a CHEK2 variant actually has a different risk than another person with a CHEK2 variant if they're two different variants. And I actually just counseled a patient the other day who was very confused about their CHEK2 risk because when they Google it, they see the risk for the highest, risk mutation or variant, and they actually have a low penetrance, we call it low penetrance variant, so their risk is actually very different. And so that's a nuance that only someone that really truly understands genetics can really help you with. Even the lab reports from the genetic testing laboratory are not that nuanced. So they'll just quote the highest risk of the variant. Uh-huh. Yeah. Pathogenicity? Yeah. Yeah. Likely pathogenic, yes. Yes. Okay, so each lab, okay. So there's lots of different ways that genes are spelled. I'm trying to think if I should show this slide and then that would explain it better. No, I love it. Okay, remind me to answer. Okay, we're gonna get to that. Okay, so basically, when we do single site testing, we're just looking at your specific variant in that gene. So let's say your relative wants to go get that test and they do a family testing program. Sometimes they're only tested for that specific variant. But if they have a different variant in that same gene, it's not going to be found if it's single site testing. And then there's also single gene testing, which is looking throughout that whole gene, but it's not looking at other genes associated with those similar types of cancers. And so people will say, oh, I had genetic testing, but then they actually only had one gene tested. They didn't have a panel. And then there's, historically, people were doing just BRCA 1 and 2, and they weren't doing these other genes. And then we have a breast cancer panel where it's only genes that were thought to be associated with breast cancer at a certain time. But now we're really moving towards these multi-cancer panels because, like I said earlier, there's so much overlap between the different types of cancers and the different genes, and we're still learning. The more, patients participate and the more research can get done, we learn more about the actual cancers associated with these syndromes. So I think that's just important to note and to remember. Okay, now we're going to talk about this VUS. So raise your hand if you've had a VUS on a report. Okay, so a few of you. So when we do any type of genetic testing panel, there are 3 results we can get. The first is a positive, which means that you had a version of a gene that we know does not function correctly and is known to cause disease. And so that's the positive, and we know what to do with that, and that means you have a diagnosis of this syndrome. And then we have a negative, or a benign, or normal variation, and this means you have a known normal version of that gene that we've seen in lots of people we know functions normally. Sometimes, and actually oftentimes, we have something that's questionable. So a version of a gene that has not been seen a lot before. And if it's not been seen a lot before, there's not enough evidence to say that it's normal or that it actually causes disease. So it's really this question of what does this do? And this is called a VUS, a variant of unknown significance or a variant of uncertain significance, depending on which lab you're reading the report of. And this basically means that, like I said, you have a version that's less common. Now, most of these are normal variation. And so we need to really test a population to understand what normal is and what it isn't. So in populations that aren't as well studied, we're going to find more of these VUSs because we don't have as much of a reference of what's a normal variation within that population. And so almost everybody I test will come back with one of these, and the vast majority of them are going to be reclassified as just normal variation. Yeah? Yeah. Probably. Yes. Yes. Mm-hmm. Yes, so okay, good question. So when we think of the word mutation, it's actually referring to pathogenic variant. So a mutation is really a pathogenic variant, whereas all of these are considered variations, like or variants. So you may have had so your PALB2 variant was pathogenic. So it's a known disease-causing variant. Exactly. We know enough about it to say that we know for sure, or most likely, right, it causes the increased risk. So that's the positive result. That's that. And then if you had the VUS or the variant that they didn't know about at the time, then it probably was a VUS. And if you were to look at that today, they may have reclassified it at this time. Yeah. Oh, that was on a previous test? They told you that? Oh, okay. Yeah, it was probably only BRCA 1 and 2 because they weren't doing these other genes then. Yeah. Okay. Yeah. Yeah. Yeah, I think that I'm guessing that you had some sort of VUS, maybe you had a VUS and BRCA that was then found to be benign or normal variation, but then they found the PALB2, and that was actual real that was a real, the answer there. Yeah. I'm guessing that's it. But we can look you can look at your results if you have them. Yeah. So that's what a VUS is. And so okay, so when we think about, when you look at your report, yeah. Oh, such a good question. Yeah, all the time. Yeah, we're getting new reports issued from the lab. So typically the lab will send the person who ordered the test an updated classification of it and say, usually it's taken off the report. So it'll say this is now known to be benign. And then they get a new report that says negative or, yeah. So it is, and the more, there's lots of research going on to try and reclassify these variants using new technologies. And there's now new guidelines for how to classify variants. So it's really going to shift. So if any of you have had these variants of uncertain significance on your report, you'll probably hear from your genetics professional in the next decade, at least. Yeah. Okay, yeah. Yes. So we think of it as pathogenic. So it's really just, so what you're talking about, the likely. So some labs will call something likely pathogenic and some will call it pathogenic, and it all has to do with the algorithm that they use to classify these variants. I have not worked on the lab side, so I can't go into too much detail. Do you know anything about? I'm going to bring up our other genetic counselor that's here. Sarah.
So likely pathogenic and pathogenic are clinically treated the same. Pathogenic has more data or lines of evidence that confirm that it is truly disease-causing. Likely pathogenic has enough to call it pathogenic, but maybe not as much evidence to be like slam dunk. Yes, it is. It is highly unlikely that a likely pathogenic will ever downgrade to VUS or likely benign. So we treat, again, likely pathogenic, tomato. Clinically, they're the same.
Does that answer that question?
Two different reports, but a lab is showing them differently. Oh,
Yeah.
Thanks.
Yeah. You're hitting on something that's a big issue in our profession.
Yeah.
Right? Because it's lab dependent. Yeah.
Very conflicting interpretation when it's two different laboratories.
Exactly. Same variant, same family, but one lab says likely, the other lab says pathogenic. And it sounds like it depends on the amount of evidence that one lab has versus.
Is using, yeah.
So wouldn't they just reference ClinVar? No.
They give their information to ClinVar.
So I guess that's what I mean. Like if all
ClinVar's
of
an
the
aggregate.
information is like deposited into one place, why would two different labs interpret all that data differently?
Because they're only using their internal data and their internal algorithms.
Got it.
Because otherwise then they're depending on a different company's internal data and algorithms, which they can't regulate.
Interesting.
Right?
Are there any movements to creating standards of
Yeah.
algorithms? Okay.
Oh yeah. I mean, I think that's a big thing in our field right now, right? And it's a big, it's one of the big things that gets talked about at all these genetics meetings is trying to do that. Now, when you have a likely pathogenic at one lab and a pathogenic at another lab, it's still a positive, but the issue that we hate running into is when you have a VUS at one lab and a pathogenic, or even a pathogenic at one lab and a benign at another, or a low penetrance at another. That is the really frustrating, because then it really depends on the lab if you're positive or not, right? Even though you have that variant. And so the interpretation of the lab is really important. Again, another reason it's so helpful to work with a genetic counselor or a genetics professional who can look at that nuance, right? The word is nuance here in that reporting. Okay. So, this is just showing that over time, as more people are tested with this variants of uncertain significance, that they get reclassified. Okay, so I'm going to have you all put on your little detective genetic counselor hats right now. And I want to use this family tree to go over kind of how to figure out who actually is the best person in a family to get tested. So let's say you have this family and the dad has a breast cancer at 42 years old. And let's say that the son came in as my patient, and he's 37, and he decides to do testing for all of the cancer genes. And he comes back negative, so he has only normal copies of his genes. Well, what does that actually tell us? What does that actually tell us? And I want to know, in this case, what the next step, can you guess what the next step would be in this situation? Yeah. You can yell it out. Test the dad, exactly. The 31? No, we want to test dad. Dad is still living in this. I should have said the slash means that they have passed away. So if we have a relative that is available to test and that's still living, we want to test the affected relative. And the reason is because we don't know if this 37-year-old is negative because they didn't inherit something, or if there wasn't something to inherit in the first place. So we don't know if dad actually has this mutation or if he didn't. And so that we call this an uninformative negative. It's still informative in that we know they're not positive for something that's detectable, but it doesn't tell us why this dad had the breast cancer and then if there's a risk that's being passed down. So now let's say instead we said, no, you know what, let's test your dad, and the dad actually had a variant or pathogenic variant or mutation. Then we know exactly who to test next and what to test them for, and that tells us who inherited this and who did not. So that would be the best case scenario. Now let's say that the father has actually passed away and is not available for testing. Then, I guess I gave it away in my slides here. The next best thing to do is to test the closest relatives. And, if we only tested, let's say, the 37-year-old, that doesn't mean that the 34-year-old would be negative, right? Because what happened is they're actually, in this family history, there was something there, and we see that it was passed to one of the children, because every time someone has a child, they have a 50% chance. It's like flipping a coin, so it's independent of each child each time. And so testing everyone there is what's really, really helpful. And when we do find somebody who's positive, then we really know who's truly negative, who didn't inherit that. Okay, so that's, I like to tell everybody to always bring in your genetic testing reports if you're meeting with a genetic counselor, and if you have family reports, to bring those in, because as you can hear today, sometimes the reports or the actual genes, we're not always going to be as helpful, and sometimes notes have something written on them that aren't actually correct, and it's just always best to have the report so that we can read that and understand that. Okay, so I was going to talk about RNA testing, but you know what? I'm thinking, how much more time do I have? I can keep going. Okay. Yeah. Okay, perfect. Okay, so I just want to cover a few things really quick. I was actually hoping that I would finish sooner, so sorry that I just, showed all these slides and yapped. But let's talk about some of the things that people ask often about, which is insurance and coverage. So we talked about how insurance should cover it, and there's some of the things to know are the Affordable Care Act, which prohibits insurance companies from using pre-existing conditions to affect rates or insurability. There's the Genetic Information Non-Discrimination Act, which prohibits health insurance and employers from discriminating against somebody based on a genetic test result, and that's only if they're asymptomatic. So that would be somebody who's a previvor who has not had any evidence of any cancer that they may be at an increased risk for. Their health insurance and employers cannot use that information against them. But as soon as they do develop a cancer, they are now covered under the Affordable Care Act instead, because they now have that pre-existing condition. So these are really important laws to know. And then I talked about testing coverage. So typically commercial insurance will cover it. Medicare and Medi-Cal will cover it sometimes, but it takes kind of some hacking around and sleuthing around to get things covered sometimes. But again, cash pay rate, $250. Then once somebody is positive for something, they can typically get their screening covered, and if it's being denied for any reason, as Dr. Potter said earlier, you can appeal, right? Because if you have an inherited mutation or you have a proven increased risk, you should be able to get that covered. Okay, so something I do like to remind everybody is that having a mutation does not mean that you have cancer. It just means you have a higher risk, and the knowledge allows you to be more cautious. And most people who undergo testing will not have a mutation, and genetic counselors are here for you if you have questions and can guide you. And I actually have, if you did want to meet with a genetic counselor, for those of you who haven't tested yet or are interested, I have on my Instagram, how do I get genetic testing for cancer risk? And it's a carousel that has a lot of ideas of how you can find one near you. Okay, thank you so much. I realize, you know what, I should have just put this lecture down, because I realize there's a few things that I just wanted to touch on just from being here that aren't in my slides. And one of those is something that I've heard a lot of Breasties talk about, which is reproduction and using things like IVF and testing embryos for these genes. So just putting it out there, it is possible to do that with something called pre-implantation genetic testing for monogenic conditions. And that means if you know that you have a single gene change for any condition, not just BRCA or cancer, it's just any single gene change that we can detect with a genetic test, we can test embryos for. So if you do IVF, and you create embryos in the lab, we can take a cell out of those embryos, test it for the genes, and then only implant the embryos that do not have that gene. Not only is that embryo not going to have that gene variant, I just said it again. I just said gene instead of mutation. Not only will the embryo not have that mutation, they will not be able to pass it on to their children. So in effect, you have now, terminated that in your family line by doing something like that. So it is something that a lot more and more people are doing and is becoming more and more accessible. So I did want to mention that as well. And yeah, I think I definitely went over, but there's so much, that I think is just helpful to understand here. So I would love to take Any other questions, any other thoughts, or any other things that have come up throughout the weekend that maybe I didn't touch on? Mm-hmm. Yeah. Yeah, that's a really good question. So we actually do know a lot about ATM. It's one, it might just be harder to find the information online. That's one that is actually also on carrier screening tests, because when you have 2 copies, did they tell you that? Yeah, it can cause a very different disease. So we actually find that in a lot. I believe, I'm literally pulling this, I don't know if this is the correct number, but I believe it's like 1 in 100 in the Ashkenazi Jewish population. I might be wrong. Do you know what I'm talking about? It's a really high rate. It's actually more common in certain populations than BRCA. So there should be more information on it, right? But I don't know. What do you think? I'm going to bring Sarah up to also answer some.
I'll try to help here. So I believe with NCCN guidelines, which have specific for BRCA, for Lynch syndrome, for Lee-Vermeini, I believe there's a way that patients can sign up for those guidelines to be notified of that. That's one way that I think of. The other thing I tell my patients is if you do test positive, check back with genetics. You're not harassing us. We love you. Come back in, please. To see us at your Hallmark birthdays, like, hey, celebrating 30, let's see what the guidelines say. 35, maybe, definitely like 30, 40, 50 is what I would suggest, because that's usually when the NCCN or other guidelines use those hallmark birthdays of let's start screening. So I think I mentioned this in the previvor meeting that with ATM, the guidelines, and BRCA too, the guidelines did update that it used to be that you had to have a family history of pancreatic cancer and a parent, aunt, uncle, grandparent in order to qualify for pancreatic screening. Now with BRCA2 or ATM, regardless of family history, pancreatic screening should be considered at age 50 or 10 years younger than the age pancreatic cancer was diagnosed. So we're no longer waiting for individuals in a family to get pancreatic cancer to be like, oh, hey, there's pancreatic cancer. I guess I should start screening for that. No, it's like a broad spectrum thing now. So that just happened in the last year. But it's hard for us to, not every genetics program can reach out to their patients to give them that notification. So we'd like for you to leave it a 2-way street here and also reach out to us with updates.
Definitely. Yeah, I think your genetic counselor is going to be the best, resource. And yeah, I wish maybe we just need to create more. Maybe we should create some Breastie resources for some of these non-BRCA genes, I know. Well, that's because that's who makes it here, And it wasn't always tested for. BRCA is the one that was tested for the longest. But Lynch syndrome is actually more common than BRCA. And that's, and nobody knows about it because they didn't have an Angelina Jolie that came out and talked about it and other celebrities that came out. So for some reason, it's just there's so much great publicity for BRCA1 and 2 and not for these other genes that are actually more common. So you should share your story if you feel comfortable, one day, just because the more we get out there and the more information they'll have, the more other people will be able to connect and information that we can get. Yeah. Yeah. Any other questions, thoughts? Yeah. Okay, you want to take that?
Yeah, so having had met Dr. Henry Lynch a number of years ago and having this conversation with him over my birthday lunch, the data swings back and forth about whether or not breast cancer is linked to Lynch syndrome or not. It is included in the guidelines that there may be a breast cancer risk, and maybe it's more with MSH6 and PMS2. So there's generally 4 different versions of Lynch syndrome, and they have different cancer risks associated with them. I generally see more of my patients with MLH1 and MSH2 have the classic family history, and I always put that in quotes because what is classic? But I don't as often see breast cancer with MLH1, but I may see it more often with MSH6 and PMS2. So at this time, it's still, the guidelines still say to tailor your breast screening for those with Lynch syndrome based on your family history.
Also, I did want to, I know some of you came because somebody mentioned BRCA being associated with more than just breast and ovarian cancer. There's also an increased risk of prostate, pancreatic, and melanoma in some cases, and it's not going to be as high as the risks for breast and ovarian, but there's still screening recommendations associated. And then, you don't have prostate, so it's that one's not something you would think about, but your male relatives who do, if they do develop a cancer, it tends to be more aggressive than the more common type of prostate. So that's something that's really important in their treatment. So that's another thing that doesn't always get talked about. And then there's also even the risk for, when we think about anyone who's at increased risk for melanoma, there's also uveal melanoma, so that in the eye. And so I will tell some of my patients who are at increased risk for any type of skin cancer that when they have their eye exams, to make sure that they know that, even in the inside of the mouth, anything that's growing there. So there's just some things to think about that aren't always talked about. Any of those other ones?
No, you hit the highlights there. I think we forget about melanoma with BRCA1 and BRCA2. I recommend that for all my patients. There was a question earlier about endometrial cancer, and I'll just say at our institution, the guidelines have updated that germline genetic testing may be considered for any individual with endometrial cancer, and we take that and we run with it. So it should fly through any insurance, regardless of age of diagnosis. And then question on the family history of male breast cancer, Dena presented beautifully that, ideally those individuals should get tested. The reality is they don't always get tested. The next of kin would be ideal. So it sounds like their sibling, who may be your mother, could be ideal. But my practice, which is maybe a bit different than other genetic counselors, is you're the patient. Yeah. This is your information. We can act on it now if you know this information for yourself. So if you have an uncle or a grandfather with male breast cancer, that would be a automatic check mark for considering testing.
Yeah, I agree. And I'm of the mindset that, same mindset. I think anyone that wants testing should be able to get it. And even though I said it's something called an uninformative negative, it's still informative. Like, it's still a negative result. It just doesn't tell us as much about that person that was affected, like what, and explaining it. And so it doesn't give us as much information, but it still gives us information. Yeah. Yeah. Mm-hmm. Mm-hmm.
So why can't we just eat more of the protein that we don't produce?
Yeah. Okay, that's such a good question. Okay, it's not the same when we think of protein that we're eating. It's not really used in the same sense as. Yeah. Yeah. I'd have to think about the best way to truly answer that in the way, because there's a lot of, I very much simplified all of it, right? So there's a lot more complexity, and when you ingest something, that doesn't necessarily mean that your body's getting it in a way, but I will say there are, some of the gene therapies are kind of working a little along those lines, and there are other genetic conditions where we know somebody is missing a certain biochemical analyte, and so we give that to them, and that can be helpful, but not really in this space. It's not really in the cancer genetics world. I mean, how would you answer that?
That's all you.
Yeah. You know what? I need to figure out a creative way to answer that question, because I'd have to go down and dig and figure out, because it's not the same. The protein, when you think of protein, eating your protein, meat, it's different than the amino acids and protein. Yeah. Yeah. Anyone? Oh, yeah. Oh, together? Yeah. Yeah. No, so because they're in the same pathway, we're really looking, you look at the highest risk one? Yeah. So because they're in the same pathway, when one's knocked out, it means, so when I say pathway, so Oh my gosh, it's like a lot of molecular biology. Yeah, why don't you?
So I think of our BRCA genes and the RAD51C, RAD51D, PALB2, they all kind of work in the same pathway. And I think of it as we have a job. We need to ship a package from one place to the other. And so one person needs to make the label. Somebody needs to put the label on the box. Somebody needs to pick the box up. So anywhere that pathway breaks down, doesn't matter. The package didn't get there. So if you have a BRCA1 pathogenic variant and a BRCA2 pathogenic variant, doesn't matter, it's not going to get there. So we generally take the highest risk from that of that cancer type, and we'll quote that cancer risk.
Yeah, it's a great question. Okay, the last thing I will mention that I realize a lot of people aren't told when they're given their BRCA or any of the cancer gene diagnosis is that if somebody does inherit 2 BRCA2 or 2 BRCA1, and so what I showed you were those 2 hits, in that case, if they were born with both, then they may have a condition called Fanconi anemia, which is a much more severe condition. And so anybody who has a BRCA mutation, really actually any of these cancer genes mutations, should have their partner tested, because if they also have it, then they can pass that down. And each of the conditions has a different condition that it can cause if it's double. So in Lynch syndrome, it's called CMMRD, constitutional mismatch repair deficiency. In BRCA and some of the rad genes too, right? Yeah. BRIP1 too, it's Fanconi anemia.
One of those is not, but yes. Yeah.
Okay, yeah. So each one is a little different. ATM is ataxia telangiectasia. CHEK2 is really high cancer risks. Yeah, right?
Yeah,
Am I missing any?
CHEK2 should be the same risks, but it doesn't count as a recessive condition.
Oh, okay. At our institution, they were. Yeah, I guess it just depends on the variants. Yeah. I guess it depends. Yeah. Oh, yeah. Sorry, what were you going to say? Oh, thalassemia, did you say? Yeah. Okay. That would be a completely different condition. Yeah. But it would be important to know if you're doing any intervention, right? That your doctors know you have a blood condition. Yeah.
So for the VUSs, if you have a VUS, some of the labs, because there's so many people that have VUSs, and greater than 90% of the time, these VUSs are later determined to be benign. We used to report them out, and we used to tell patients that, hey, remember me? No, you don't remember me. All right, your result we didn't worry about 10 years ago is now benign. We're really not worried about it now. Some laboratories are no longer reporting out when it's classified from uncertain to benign, because that's clinically the same. But they will always tell the provider that when it's a VUS upgraded to pathogenic, then that provider that ordered the testing should be reaching out to you with an updated report. If you've moved or you're no longer in contact with that office, consider touching base with a genetics provider to say, hey, I had testing. Is there any updates on this variant? And we're always happy to check in with the laboratory for that report. But just wanted to comment that VUSs, if they are downgraded to benign, you may not get any messaging from your provider's office about that.
Thank you. Yeah. Mm-hmm. No, we're not usually. So we can sometimes see a second cancer variant, but it's usually when we see other cancers in the family, right, that aren't associated with BRCA. So if you have a further suspicious history for something else, then we might think about that. But yeah.
Yeah, so in 3% to 6% of families that have a known cancer gene mutation, we will incidentally find a second or different gene mutation. So it's not common, but if there is, both sides of the family look suspicious for something, or if there is a pattern, like early onset kidney cancer, that's not typically explained by BRCA, or other cancers that may warrant updated test, colon cancer, that may warrant updated genetic testing. But the reality is, like, once you have BRCA or Lynch syndrome, if you didn't already have a panel, there's no guideline to say you should get an updated panel unless there's additional family history. What I more often see is, all right, you've tested positive for BRCA, then I might see your sibling, they come in years later, they get tested, they get a panel, and we surprise find something different. I just had this with a family that has BRCA on one side, Lynch syndrome on the other. We tested the adult for Lynch syndrome, and they had a different gene mutation, but it's because we just do panels for pretty much everyone these days. So now we're able to inform, okay, this came from the other side of the family. So realize you may not need the updated testing, but as long as your family members are getting the updated testing, if there is something, we'll probably find it.
Yeah. I also, this is not a guideline. This is something that I have done for my patients. But if they're going through IVF for PGT, yeah, then I mean, if you're already doing that and you can do a panel and it's inexpensive, then I mean, we would not want to not do it and then go through all of that and then find that there's another gene there. So I always offer that in that case, yeah.
Or if I have someone who's BRCA positive and they're diagnosed with a new cancer, at our oncology center, we'll think about repeating the testing for that person just to make sure there's not any secondary germline findings. But that's not a guideline, that's just my institution.
Yeah, that's very dependent. Uh-huh. Yeah, BRCA will be higher. Yeah, that would. No, not really. No, we would assume that we would use the BRCA risks for their screenings. Yeah. Yeah. Okay.